Get to a conversation of the day, and we are speaking about glaucoma. Now, this is the month where awareness around the same is normally done, and specifically this morning we shall be talking or focusing on childhood glaucoma because most people associate the condition with the elderly or older people, but actually this is something that also affects children. But before we get to the nitty-gritties of it, let's familiarize ourselves with exactly what glaucoma is, and if we can have those graphics on air. They say glaucoma is actually a group of eye conditions that can cause blindness, and there are various forms of glaucoma, and our doctor in studio will be giving us more details on the same symptoms. Some people may experience sudden eye pain, headaches, blurred vision, distorted vision, complete loss of vision, and it's interesting they also say some people can go without the symptoms. And treatments, it is said it consists of anti-glaucoma medication, could be eye drops and or surgery. Well, in studio to help me delve into this conversation, even as we focus on childhood glaucoma, is Dr. Dan Mundia, who is an ophthalmologist and a childhood glaucoma specialist. Thank you for your time. And we have Dorcas Wanjiro, who is a caregiver and a mother to a 5-year-old boy living with glaucoma. Thank you for making time. Well, Dr. I'll start with you so that at least you can paint a picture for us about glaucoma. What exactly is wrong with the eye when we speak about glaucoma generally?
Thank you. Good morning, viewers. My name, as you heard, is Dr. Mundia, and I deal with pediatric diseases, and glaucoma in pediatrics or children is one of them. Now, when you talk about glaucoma, we are talking about a group of diseases that damage the optic nerve of the eye due to high pressures in the eye. The eye is essentially hollow, so it is filled with a fluid. And there is a way this fluid is made or produced within the eye, and then a way is created by God on how this fluid exits the eye, so that there is a kind of constant pressure in the eye to make it turgid and round, like you see it. So if there is derangement in this production versus drainage of this fluid in the eye, the fluid will accumulate in the eye and cause build-up of pressure, which has then transmits that pressure back into the optic nerve. Optic nerve is the nerve that supplies vision from the brain into the back of the eye. So once damaged, then vision drops and sometimes becomes blind.
Okay, now that sounds like something that is a gradual process, but the truth of the matter is, and that's why we're focusing on childhood glaucoma today, is that this is also found in children and some even at birth. What could cause that?
Rightly, as you say, it is a gradual process in adults, but in children, these structures that produce the fluid and the channels through which the fluid exits the eye may not develop very well. So in children, you're not talking about a gradual process. We are talking about a defect that happened in the womb of the child due to either a genetic problem or maybe some drugs that the mother is taking, and that the channels are not draining the fluid, and that build-up of pressure now causes the damages that probably we are going to delve in the following talk.
Okay, so at this point we can really endorse is now your son was diagnosed with glaucoma at 2 months. Yeah? At birth? Okay, so exactly what was wrong? What did you notice that was not normal?
Okay, thank you. Good morning, viewers. What happened after birth, like a period of 2 weeks, I realized that my son's eyes were being covered with a whitish substance. Something you could not see the cornea. It was completely covered and it was completely white. Okay, then I went to a local hospital. I was given some medication. Then after 3 days, we were to put the medicine for like 3 days. After that, the signs were recurring. So we decided with my husband, we decided that we are going to take further action. Actually, I took my son to Machakos Hospital. Then we were referred to Kenyatta Hospital. That's when they discovered that my son was having glaucoma. Okay.
So in that case, what was the first point of contact? What did they suggest you do? The first time they gave you what, drops?
You know, the doctors in Kenyatta, they said that my son was having pressure in the eyes, and I could not understand what is pressure in the eyes. Then they gave me, I don't know the name.
Yeah, but was it an eye drop?
Yes,
okay,
to reduce the pressures in the eye.
Okay, and Daktari has touched on the fact that it could be genetic or something that probably happened during prenatal. Do you have glaucoma in your family?
Well, not all I know of. I don't know.
Okay.
Yeah.
All right. So in this case, I guess it's left to speculation whether or not it's something that happened during pregnancy. So Daktari, back to you. In that case, she was given eye drops to help relieve the pressure,
Yes.
but it did not work. How do you now decide which one you would go the eye drop way, or others that you now say this one is a surgery case?
The glaucoma in children, sorry, the structures that drain the fluid are not well formed, and there's blockage in that structure. So we know that from the onset, treatment with medicines or drops will not work in children. And therefore, we give drops as a temporary measure, 1 or 2 weeks, awaiting probably treatment of the child that or stabilizing the child for theater, because eventual treatment for child glaucoma must be theater. So it was a temporizing measure to await surgery in the case of Dorcas' son.
Okay, so what was the next course of action when the eye drops didn't work in your case, Dorcas?
Sorry.
After you put the drops and it wasn't working, what did the doctors suggest you do?
Actually, from the start, the doctors had already told me that it was an operation case. And you know, it was very funny because my son's eyes were bulging out.
Oh.
They were bulging out. Zilikuwa zinafura zikitoka nje. And after asking the doctor what was the cause, he said that it was because of the pressure, and so they quickly booked me for an operation.
So this was at 2 months?
Yes.
Okay.
Yeah.
So what, did it relieve the pressure?
Yes, yes. After the operation, the boy, you know, at first he was very, very, very stubborn. He was crying all the time. He was restless, no sleep. He was, I mean, he was a boy who okay, hakuwa anatulia. Wakati wote alikuwa analia. Mara mingi kama ajalala, it is either you breastfeed him because he can't keep quiet. He was always crying. Yes.
But after the operation,
He was cool, he could sleep,
yeah.
and everything turned out to be
Okay.
cool. Yeah.
All right. Now, before we get to where he is today, Daktari, there are many types of glaucoma in children, and you probably would be the best person to tell us. We've read on congenital glaucoma, but if we can have the pictures on the screen just to help us walk through some of the types of glaucoma in children. There is a picture on screen. If I can have that, what is that one called exactly? What type is that?
Now, to start, probably when you talk about the types, I would probably classify the types in terms of when or the time at which we discover it or when it happens. Like Dorcas' son was born with the disease, came out of the womb with the disease. That is true congenital cataract, congenital glaucoma. Then there are those that are going to be discovered between birth and 3 years of age. We call them infantile glaucoma. And probably, like we said of the adults, this is a progressive disease. Then there are those that are going to be discovered after 3 years, and we call them juvenile glaucomas. So those are the types of glaucomas we're talking about. And the picture on the screen is what we call a true congenital glaucoma. Probably Dorcas will probably recognize
yeah.
the right eye.
So is
where
that
it was
how?
totally cloudy.
Both the eyes were like that. Both.
Both now, like the one
Left.
on the left,
Yes.
the
So,
cloudy one,
yeah.
okay.
So this is an infant who probably was born with this, and you can see it doesn't have to be equal in severity, because the right eye is totally cloudy, the cornea is totally cloudy,
Yes.
where the left eye is
Clear.
moderately, it's not quite clear, but it's moderately cloudy.
Yeah.
And the other thing to show in this picture is that I had one parent tell me that they came late because they were thinking the child has beautiful eyes. Big eyes, of course, are beautiful eyes.
Yeah.
And if the right eye was not as cloudy, probably this parent would say, my child has beautiful big eyes. But you can see the eyes are a little bigger than normal.
Yeah.
So that's the first sign that tells you, hey, my child may be not normal.
Yeah.
So not all large eyes in children
Actually
are
normal.
actually normal
Okay.
or beautiful.
Yeah. Well, I noticed one of the pictures, if we can play that clip again. Some of the pictures, this one is a definite glaucoma case because you can see the difference between one and the other. But with the other picture coming up, the child looks almost normal. The eyes are just, as you're saying, big round eyes. And if you can get to the next picture. So in this case, you were saying that's the bulging that you were seeing, Dorcas, in your child's eyes?
Yeah.
Okay.
In this case, probably, you can see the child is asleep, but you can see the right eye
Is
It's really
bulged.
bulging.
Now, in this case, the child, they look normal. Are you saying that one could be a telltale sign?
This is actually the parent who said that the child looks like she thought the eyes are beautiful, and people used
Yeah.
to tell them
That
the
they have
child are
such beautiful.
But
Okay, now to the layman, that looks very normal. Tell me, what is different about this child and a normal eye?
it could be different because this child have taken this picture after treatment. Because they were beautiful immediately after birth and probably the first 2 weeks. Then they started becoming cloudy. The child started tearing and fearing light. And the mother became concerned that every time I switch on the light or I go to the sun, the child doesn't want to see the sun. And like Dorcas says, the child becomes very irritable. The child cannot, of course, describe pain, so they can only cry if there's pain in the eyes. And you can see this is a case that came because what is happening to my child?
Yeah.
And of course, the cornea had started becoming cloudy. So the beautiful eyes were no longer beautiful or comfortable to the mother.
Okay, Dorcas, even with the film on his eyes, could you tell if they could see?
Okay, I couldn't tell. No, the child was still very young.
Yeah.
At 2 weeks, he was very young. I couldn't tell whether he could see or not. Yes.
So at 2 months still, you couldn't tell if that had changed?
After using the medicines for the drops,
Yes.
okay, the cornea, okay, the haziness was reducing kind of.
Okay.
Yeah,
But it wasn't
not complete.
not completely.
Yeah.
Okay, Dr. at that point, when you're having the symptoms, is a child able to see but with difficulty?
Yes, and like you saw in the pictures, it depends on the severity. If it is as dense a cloud as we saw on the
First picture.
first picture, the child is not seeing. Probably just perceiving light. When the shiny light is shown, they can perceive that. But they probably see movements but cannot discern any image. But of course, when the cornea clears up, they can see. But of course, with other complications, probably they cannot see as well.
Okay.
Yeah.
All right, which brings us to the common signs and symptoms that you were touching on. Earlier, we just talked about the general signs and symptoms on adults. Now, for that child, you said sensitivity to light. You talked about, for example, the child cannot now say they have sudden eye pain, headaches, blurred vision, and all. So for a child as a parent, what should you be looking out for?
I cannot say maybe lucky or unlucky ones are the ones who show big eyes that are cloudy, that because they are brought early. But there are these kids who probably are late developers, and the mother could notice that the child is tearing a lot. Usually, if the child is comfortable, you shouldn't see a lot of tearing. Then they fear light. We call it photophobia. Whenever they go to the light, they're just crying or closing their eyes. The other thing is, of course, cloudiness of the eyes, and that's what probably the symptoms from the mother would come. restlessness, like the doctor is saying. They can't sleep well, they can't eat well, and this probably will develop very suddenly. The child was okay until last week when these symptoms started. Then when they come to us, of course, we can see the big eyes. In fact, congenital glaucoma is called bullthumos. In other words, it's called like a bull's eye. It's big eye. Bullthumos means bull's eye.
Yeah.
So you see this child who looks like she has a bull's eye, then it's a concern. And of course we see the cloudiness, which means that the pressure in the side of the eye has pushed water into the cornea to become as cloudy as we see. Then we, of course, if you are able to see inside, we can see the damage to the nerve.
Okay.
Usually in the hospital, we are able to, of course, take pressures. They are to see whether they are within normal ranges. It's not very easy in a child, but of course we have to take them to theater to determine whether their pressure is normal or high.
Okay, the conversation this morning on NTV Today is childhood glaucoma. We're having this conversation within the month of awareness of the same, generally about glaucoma. But in Kenya, we are looking at childhood glaucoma because, according to statistics, 6%, it makes 6% of total blindness in children. So there is a need to have this conversation and be aware of how and what to look out for. Because after the surgery, did the milky eye totally clear?
Immediately after the surgery, the eyes were very red, so we had to use still some medication. But then after like a month, the eyes were back to normal. Yes.
And what happened to the bulgeness? Did it now go back to normal?
Completely. The eyes were no longer big. The child was relaxed. He was not crying. But the only problem that I found after using the medication was that still he was okay. To light, you could not, ukiweka light mingi sana, alikuwa na bado anaogopa. But
so
then
still sensitive to light.
But then after some time, everything turned back to normal. And you know, the funny thing is that the child had to wear glasses from 6 months. 6 months old.
Yeah.
He was on glasses, and it was very funny because whenever I was in a vehicle, somebody could tell me, "Well, stop, wacha kuweka mtoto hizo vitu." It's like unaharibu macho ya mtoto.
Oh, they are thinking this is a cosmetic
thing.
Yeah,
because it was a plastic
lens.
Yeah.
Okay.
Yeah.
All right, Daktari, 6 months, a child wearing specs. That's quite out of the ordinary, I must say.
Yes, it's not out of the ordinary, but we need to educate our community more that wearing specs is not that bad. But Dorcas is actually describing the sequence or sequelae of the disease.
Okay.
Since the eye has blown up, it's big, the images can no longer be focused at the back of the eye because it's long eye, and inevitably they become myopic or short-sighted. And that's why we give glasses. And thank you, doctors, for using glasses despite the discouragement. We insist on that because, again, we could do a very good job of operating the kid, the cornea clears up. But if we don't now go to the next stage of managing the complications, like short-sighted is one of the complications, then we will not have done much. So, yeah, it's expected for all, because of the beginners of the eye, we expect them to be short-sighted.
Okay.
Yeah.
Talking about childhood glaucoma, as I had actually touched on earlier on, it's said to comprise 6% of total childhood blindness, which is a huge number, Daktari. And in this case, is it increasing in Kenya if you were to look at the numbers, the prevalence rate in Kenya, or is it something that has now been curtailed due to some more information on the same?
Thank you. Of course, if they're increasing because our population is increasing. So, and luckily we are having quite a few centers now that treat this disease. I think previously we only had probably 2 or 1 center, but now I can count 5. So, and people are becoming aware. People are becoming more responsive. They're bringing the children as early as months or weeks. And so we are able now to curtail the disease. But of course, we know out there are quite a few that are still coming 5 years later, 6 years later. So there are pockets in Kenya that the children are still lying at home.
Okay, before you tell us on which pockets they are, Dorcas, you say he was diagnosed at birth. Who noticed it? You or the nurses?
Okay, I remember one day I was just in the house, my husband was at work, and then the child, when he woke up, the eye was completely covered. And I was like, you know, the first time I called my husband and I told him, mtoto amepotea macho. Cause, you know, after 2 weeks, it was like, yani once. Unajua alikuwa analia, but sikuwa naelewa shida ilikuwa wapi. But then when sasa wakati aliamka nikaona hiyo macho imefunikwa kabisa, niliona mtoto kabisa amepotea macho.
Okay, so help me understand. After birth, when you're in hospital, his eyes were normal?
He was normal.
So it's up until you went home?
Yes.
That now he woke up with a film over his eyes?
Yes.
Okay, so in that case, Daktari, the question would be, those in hospital, there are some cases that it shows, does it show immediately the child is born, or some actually delay the, like Dorcas's did?
Like I said, on the second type of the glaucoma, the infantile type, who will be born like normal. I would say like because usually if you're keen, you may find something. And of course, the mother would say, this is normal-ish eye, until something happens suddenly, like the cloudiness of the cornea happens.
Okay.
That is the infantile type, and the majority of the children lie on this type, where between birth and 3 years, that's when the incident happens.
Okay.
Yeah.
Now, if you're saying if you're keen, you can actually tell there's something off about the eyes. Are those service providers, the nurses, the doctors, the midwives, are they trained enough to actually understand and see what, know what they're looking out for?
Unfortunately, not to the level that we would like, because unless somebody has gone through an eye hospital or an eye unit, probably you don't know a cornea that is literally looking a little bigger than normal, but still clear, that would pass, I would say. So like doctors, nurses did probably just pass their notice. Yeah.
Okay, now what are some of the complications of glaucoma if it goes, you know, unnoticed and you come to you very late? As you were saying, some come way late, like the child is 6 years or so. Apart from blindness, what else can we be dealing with?
You can imagine of an eye that has high pressures for 0 days to 3 years, that eye will be huge. It will be a huge ball. So it will be unsightly even to look at. The child, of course, cannot see light, cannot look at light, cannot even open eyes for some time. The eye is exposed because now it is out of the cover of the lids, so it becomes an exposed eye and an irritated eye. So there's always crying and tearing and redness. And then, of course, now inside the eye, because of this stretching out of the walls of the eye, there are structures that inside now become damaged. The lens, which is suspended in the eye, the suspensory ligaments or the stitches, the sutures that stretch it or hold it in place, get stretched to the point of snapping. So once the ligaments snap, the lens inside, which now focuses images in the eye, can fall in, can now start wobbling in the eye, which causes more trouble. The stretching of the eye also causes what we call retinal detachments. So there are many complications in the eye, and of course that by this time the nerve is already gone.
So that means blindness.
Yes.
And there is no reversal to the same reason.
Once the nerve is damaged 100%, there is no reversal, and we have not discovered how to treat it.
Okay. Now, Dorcas, you say your son wore specs since he was 6 months old. How has that changed with time? Because I'm assuming as he grew older, either something got better or worse. What is the case in your case?
Okay, in my case, the child has improved. Okay, the child has improved very well. He has been ako shule sahi, anasoma, anaelewa, na I see it has improvements. Yes.
He's 5 years old and having to wear specs. There must be challenges of ensuring that he keeps these specs intact for his own good. Speak on the same as a parent.
there are so many challenges of a child wearing specs. Okay, every time he's breaking the specs, mara nyingi ametoa lens, mara amepeana imepotea, mara nyingi yani, like now he's not on glasses, ameshapoteza. Now we are in that process kutafuta tena zingine, and you have to go to the hospital uandikiwe tena mpya, because you cannot describe for your own. You have to go to the hospital uandikiwe tena fresh ndio uende ununue specs. Mara nyingi anazipoteza, mara amevunja, mara amepea friends wa share, you understand? Yes.
Okay, because he's young and he's a boy, he's just being a child.
Yes.
Okay, which speaks to the cost of treatment. It must be expensive to ensure that he gets the support he needs.
Very expensive. Yes.
What are we talking about? What do you look at? Are you still using medication? And of course, apart from the costs for the spectacles?
Okay, right now, no, it's only the wakati tunaenda clinic, maybe sasa hiyo ndio gharama inakuja, because tunaendanga clinic twice. But now, right now, it's only after some months. Initially, we used to go to the hospital like every week. Tulikuwa tunaenda hospital. When he was young, hospitali twice a week. Monday, tulikuwa tunaenda Tuesday na Wednesday zikifuatana. And it was, okay, initially it was very, very costly, because unaona unaenda hosi, sometime unaandikiwa dawa expensive. And right then tulikuwa financially tuna strain kabisa. Unaelewa, I was there, niko kwa nyumba, mzee peke yake ndiye ako kazi. And by the way, I like to congratulate my husband. He really supported me. He really supported me. Thank you so much kwa kunisupport. Alinishikilia then. And with the parents too, they were pia walitusaidia sana. Because, okay, and then the gharama ingine yenye ilikuwa juu sana yenye niliona ni wakati wa operation. Had it not that we were covered by the NHIF, I don't know whether we could have made it. It was very expensive.
Okay.
Yes.
All right. It's a good thing that she touched on NHIF, because the question is, I have this issue, do I have any reprieve when it comes to the costing? Is that something that is also reflected on in insurance covers? Because we could have NHIF, but I wonder how it looks like with insurance covers.
I'll be very careful when I talk about insurance covers, and especially with the ongoing doctors' issues of prices. But, and if they're listening to me, insurance covers refuse to cover congenital cases.
Oh.
It will be an exemption in most of the insurance covers. That has been turned around by NHIF right now, because NHIF covers everything, and probably that's why we are seeing more kids early with the disease coming to the hospital. So I think it is helping a lot. But other insurers, I think they need to look into that.
They need to pull up their socks. And speaking of which, she talked about the stigma she had to deal with a 6-month-old wearing specs. I can imagine she is in town and she had to deal with that. Somebody who is in the mashinani does not have access to the spectacles, does not have the money to take their child to hospital. How does it look like in the counties when it comes to treating glaucoma or even detecting it?
That's the biggest challenge we are getting in treatment of congenital glaucoma. One is like presentation. These people come to us, probably have passed through the local health center. They are sent to the local level 5. And it takes even years before they go to the level 5. Then level 5 sends us to the tertiary. Before they come to the tertiary level, it's a year or two later. So the disease is no longer what she saw the first time. Secondly is, if a kid in Turkana, say, was told to come twice a week, or twice a month, or once in a month, you'll bear that they will never come. So the biggest challenge we're getting is follow-up, and especially those who are outside Nairobi. And cost, of course, like she has touched on cost, it is expensive to come, even traveling alone. The clinics, of course, there are centers that probably even care for such children in Kenyatta, in Kikuyu, probably in Arakan. They have a fund for that. But yeah, it is a costly affair, and follow-up. We need all of us, doctors, community, to pull our socks on getting these kids to come back to the hospital.
Okay, now glaucoma is definitely treated by ophthalmologists, I mean specialists in the same, and the question would be how many of those are in the country to start with to help, you know, alleviate the issue, and we'll be getting to the details of the same even as I continue having this conversation around childhood glaucoma within the month as of glaucoma awareness. That is Dr. Dan Mundia, ophthalmologist and a childhood glaucoma specialist, and Dorcas Wanjiro, who is a caregiver to a 5-year-old boy who was born with glaucoma. Dr. Before we went to break, I needed you to tell us, in the cases where we're saying in the mashinani, where those that cannot get help really do not know what to follow up with, the question is, do we have enough specialists to help with the need that is?
The answer is no. The ideal position would be every level 5 should have a specialist in childhood blindness. We call them pediatric ophthalmologists. Right now, the few that are, we are probably 90% in Nairobi, and probably one in Mombasa and one in Eldoret. That's all. So in between, as far as the distances, we don't have specialists.
Okay.
But the ideal thing is every level 5 should have a specialist.
Okay, now, Dorcas, you touched on the fact that you go to Kenyatta.
Yes.
And there's a time you went there more often than now. As the boy grows older, the trips to the doctor are less. But every time you went, you had to pay something. Talk about the cost and the convenience of trying to keep the treatment going for the sake of this child's sight.
Sorry?
How were you able to sustain that? Yes, you had NHIF, but the other costings that came around making sure that your child got the treatment that they need.
I've said again, and I'm going to repeat that it was through the support of my husband, through the support of the parents. Actually, the most cost was on my husband's shoulders, because I was in the house. I had just given birth. He was the one who, and you know, he used to work at Juakali then. It was really costly, I tell you. And we were going through a very, very hard financial constraint. But I thank God, all in all, He has been us and He has carried us through. And now the child is all right.
When you were going to those clinics, there were some women, I'm sure, or parents that did not have at least a support system like you do. What was their testimony? How were they being able to sustain the treatment?
Okay, you know what I say, like, wamama wanakuanga, okay, they are really hard workers. Some of them you could hear mtu anasema hata anafanya vibarua, mwingine anasema anafua nguo ili aweze kutafuta pesa za kuleta mtoto clinic. Actually, wamama, some of these women, they were going through a very, very hard and tough time. Yeah, they really strained, but then, you know, kama unapenda mtoto wako, you do anything ili uokoe hayo macho ya mtoto. Yes.
And speaking of that kind of dedication, Daktari, you have a child that has been diagnosed with glaucoma as far as Turkana, and you say the numbers of ophthalmologists on the ground do not they're not the same as the need on the ground. So what happens to that parent, because they have to get the treatment, but the treatment is not close to them? What now?
You can imagine how difficult that is, because first of all, that I don't know where the first contact would be for that child. Where would the mother take the child for the first diagnosis, so that they are even sent to the next level? And supposing they even come to us and we treat them, we do surgery, you can imagine Turkana, even if you were to tell them to come once, like every 3 months, they'll tell you, no, I cannot afford. So it's a big challenge, and that's why we probably say we need the closest hospital, level 5, because Turkana is a county. There must be a level 5 to have a specialist, because we definitely will lose this kid. We'll treat the kid. When they send them back home, probably they will see a bit of improvement, and that's all. We never see the kid again.
Okay, and there are some eye treatments. For example, you'll hear there's a clinic that has come with doctors, a camp of sorts where they'll treat cataract and what have you. Is this something that's normally applied when it comes to glaucoma?
No, for childhood glaucoma. Of course, when such a camp, which would come in like this one after every so often, and probably, and I can tell you the persons who go to outreach are usually not the specialists. They're probably health workers in the hospital, lower cadre, that are able to go and do the screening. So probably in such a clinic, they would probably see that child and offer some kind of treatment to start with and tell them to come to the hospital. Usually the outreaches are to screen, treat the simple ailments and refer the rest. So if one is from Kikuyu Hospital and is in Turkana doing the outreach and is sending the child to Kikuyu, because that's when they know, where they know there's a specialist.
Yes.
It is just left for the parents to decide whether they can, one, afford, or they are keen enough to come to Kikuyu, if they ever find their way to Kikuyu.
Okay.
Yeah.
All right. Now, at this point, I think, apart from you being born with it, whether it's to do with a prenatal issue or genetic, the question would be, are there other ways of actually getting glaucoma, like an injury of sorts?
Yeah. When I talked about congenital is probably something happens in the womb, or the disease having developed in the womb. The infantility is within 3 years. Majority of what comes after 3 years, what we call juvenile glaucoma, usually is because there is another additional cause, either injury or infections to the eye, or somebody has another disease like TB and that affects the eye, or they could have another infection elsewhere in the body that also affects the eye. So the group that we call juvenile after 3 years of age is usually because there's a secondary cause. The child is born normal, will be normal up to 3 years, and some other event happens in the body that causes derangement in the way the aqueous or the fluid in the eye flows out. Yes.
Okay, for your son, Dorcas, he now doesn't go to a hospital as often, but every time you go, what is the purpose of a clinic appointment? What are they looking for?
Okay, they measure the pressures. Sometimes they want to know whether the glasses are, unajua wakati mtoto anaendanga akiimprove, they keep on changing the glasses. Unaambiwa sasa hata vaa hii, unaandikiwa zingine, unaenda unanunua zingine. Yes.
So in this case, we got from bad to worse. I mean, rather worse to good. It's getting better and better. His vision is getting better.
Every day, yes.
Okay. Do you still use additional eye drops or something to help him?
The only eye drops I use is the Atrodrop. Hiyo dawa ya kufungua macho wakati anaenda kupimwa hizo pressures. Kuna dawa tunaweka 3 days before uende hospitali ndio macho ifunguke ili daktari aweze kuona ndani ya macho.
Okay.
Yes.
What does she mean, macho ifunguke? Eyes are normally open. What exactly is being opened?
Thank you for that question, because treatment of children's glaucoma is very different from adult. When an adult comes in my clinic, when seated in my small clinic, I can determine a lot because they can cooperate. I can measure the pressures from the clinic. I can even examine the eye because they are cooperative. In children, they are not as much cooperative. So one is that if you want to see the inside of the eye, there is something called, there is an opening in the eye called the pupil, the small opening that shuts off when the light is too much. It's called a pupil. And when it is too much, too small, you can't see as far back as where the optic nerve is. So we would like to open that or make it big in a way that when I shine the torch, it doesn't close back, so that I have the liberty to look inside the eye without much hassle. In children, again, because of the way we would want to handle, if they're coming to my clinic, those drops may be stinging. And if I do it in the clinic, they will associate the doctor with the stinging. So what we do is to tell the mother, do it at home, and probably when they come to me, they don't associate what you did at home with what I'm doing in the clinic, and they may allow me to examine the eye.
Okay.
Yeah.
All right, Dorcas, earlier as we were speaking, you said surgery worked for you and your child is improving and they're in a good place. But you said there's a woman you met who had been there severally.
Yes.
Yeah?
No, okay, wakati unaenda clinic you talk with so many people. Kuna mama tulikutana naye, then she was complaining that his child, he was a boy, he had been operated like 3 times. Was by then, by the time I saw the boy, he was like 1 year, but he could not see at all. So I, when I got in sasa wakati tulikuwa tunaongea na daktari, I asked what could be the cause, why is not there's a woman who has told me there that the child cannot see, and then she told me, you follow the doctor's instruction. Then if you follow the doctor's instruction, you're going to be on the safe side. Yes.
Okay, Daktari, 3 surgeries later, this child was a year old and could not see. Why is it that some are more stubborn than others?
Thank you for that question. When you talk about congenital glaucoma, even those that they are born with, especially those ones, we have those glaucomas that are primary. We call them primary. They are just probably the drainage channels have a membrane or a covering that can easily be removed. The second group is where there is an associated other abnormality of the eye. You remember I said probably, we said that there is an abnormality in the structure of the eye, especially the channels that the fluid exits through. There could be other, because of that genetic abnormality that might have happened in that eye. There could be other associated abnormalities of the eye. There could be that the other layers of the eye did not separate well. There could be additional lens abnormalities, additional structural abnormalities, and that means if you are removing only one part of that, like when you do a surgery, we are removing the abnormal membrane that is covering the channels. You have not removed the other abnormalities, and some of them are even not treatable. So those are the stubborn type.
Okay.
Because there's a second or third abnormality. Remember, if there's a derangement in development, it doesn't come alone. So we would watch out for those ones who have second and third abnormalities in the same eye. So it's not glaucoma per se that is stubborn. It's because there's another abnormality that's probably untreatable.
Because I needed to understand the support system around this child. He's 5 years old, meaning he's school going, and he wears specs. He has a special condition. How does the education system help you in bringing up this child?
We in school we have very cooperative teachers. Okay, wakati nilimpeleka shule nili-explain hiyo condition yake, and the teacher was very supportive. Yeye huwa anakaa mbele, and my son, he's the lucky one because hata akiwekwa nyuma yeye huwa anaona, but mostly na advice teachers akae mbele. And he's a left-handed boy. So they really, and then he's friendly.
Okay.
It is very easy to accommodate the boy.
Okay.
Yes.
Do you feel the need to probably tell even those other caregivers at home to be aware of some things he can do and others that he can't do? Or is he at home, he's just a normal boy and can do anything and everything?
He's just a normal boy. He does everything. He plays like a normal kid. The only sensitive part is that I always fear atavunja either glasses, na wakati mwingine sasa wakati anatoa hizo glasses akipea watoto, hiyo tu ndio ile part. Sasa mara mingi naambianga wazazi karibu na mimi, ukiona ametoa mwambie arudishe ama uniletee hizo glasses. Yes.
So does he wear them with that assist on his neck?
Yes.
But he still removes them.
Anatoa, anashare na friends.
Yes. Okay, now Daktari, I mean, these are children that are not only being treated, but they are going on to have a normal life. But normal can only be so much considering the kind of or type of glaucoma they're dealing with. How does now the specialist help along in making sure that all the pillars in his life understand the condition?
Yeah, it's so like you said that it can only be so normal. To start with, when a kid has not had adequate vision from the time of birth through 6 months to up to 2 years, the development of the eye and the brain, that connection does not happen fully. So even in the case of Dorcas's son, because of the small interruption at the beginning, we know that it's not 100%. And a good unit which offers services to these kids, they have a backup of what we call low vision therapists. Low vision therapists are a combination of nurses who have gone to learn about vision, and teachers who have come now to the hospital setting to understand where the disease comes from, and they can again advise on schooling. So this backup, what we call low vision clinics or low vision therapists, they can assess, even if we treated this kid and we got this far, what is the residue? What can they do? They're able to assess how far, even this case of the son, how far is this short-sightedness? And even with glasses, how far do they see? Of course, I think from her story, I think that's a success story. We have many that do not go that far, and they have just a little vision probably to walk or to write or to just read. Some of them are even doing Braille in brain schools. Now, this support system, which is available in good units like Kikuyu, will tell the teacher this kid needs to sit so far from the board, even if they had good classes. Or you need to write these big letters for the kid. And even in the exam situation, because of the disability clause in our constitution, we are able now to say, even in exams situation, give them this kind of font in their print so that they are able to see. So all that backup is available. It's not widespread. There are only probably 2 units in the country that can give you that. But we issue out letters to relevant authorities, schools, examination bodies, so that there is that backup.
Now, Dorcas, you mentioned that you tell other mothers when they see him remove his specs, wanamwambia avae. Now, as you walk this walk of bringing up a child with glaucoma, do you have other mothers that you know that are living with the same situation as you, that you walk together, mpatiane nguvu?
Okay, the only mothers that I know of is when we are in clinic, not around my home area, but then in my home area, nimesaidia watu wengi kuelewa ya kwamba ukiona any complication ama anything tiny kwa mtoto, take a step, enda hospitali, elewa hiyo ni nini, because the small things that we assume and just let go, hizo ndio vitu huwa zinakuja kuwa milima kwa maisha. Yes.
Which is a very good initiative, Daktari, and I'm wondering, from your point of view as a specialist, the group that you have, these specialists that take care of childhood glaucoma, is there any initiative out there that helps in creating awareness?
Yes, and especially the ones that's run in Kikuyu, and it's a national program. They have what they call, I think, low vision education or something, where they call all the mothers with blind children or like suboptimal vision to come together. They teach them, they interact, they motivate them, and they tell them what support they need out there. I've not had like a group that is Congenital Glaucoma Association or something, and probably that's where Dorcas is talking about, and we are talking about, and which would be very good. But I know that there's this initiative of bringing them together, staying together for about a week, where they come with their children, they're shown what to do at home, and that way they interact, they know which other, who the other mother is and what they do for their kids. I know in Nairobi, and I'm not in that group, that there's Kilimani group of a women group or something.
Kilimani moms.
Once in a while I see referrals from that. And somebody says, oh, okay, how did you know about me? It's like, oh, there's this group that talked about when I raised my issue, everybody contributed and gave your name. So such fora have been very helpful in referring of such cases and in even education among themselves.
Okay.
There's also, I think, Gertrude's village moms or such like this. One can join. It's an online group. You may not meet physically, but it's an online support group.
Okay. Alright, even as we bring this to a close, the challenge to stakeholders in as far as bringing the sensitization of childhood glaucoma and of course the support system for those that are bringing up children or caregivers of children living with glaucoma.
Thank you. I will start with a story. Recently, I think last week, I called my cousin who is in the insides of Olkalau, and had gone to Olkalau hospital because the child was sick. That is eye disease, and was told from Olkalau to go to Nyahururu for a specialized care. So when I called him the next week, he said, I was told to go to Nyahururu. I'm still looking for ways to go to Nyahururu. And that is about a difference of about 60 kilometers away. Now imagine a kid who is in Turkana or Mandera, Wajir, who has been told to go to the, because the health worker in the facility nearest to them, probably a health center, has told them to go to the next level, a district hospital or a provincial hospital, which is called level 5, and they are thinking, how will I reach to that hospital? And they are hopeful that when you go to level 5, my issues are sorted out. Now come to glaucoma. You go to the health center, you are sent to level 5 after probably incurring cost to find ways to go there. You are told now, the next step is Nairobi. So I would urge the county workers, the governors, the commissioners in the county, to think about this facility, the facility they have, and what they're offering at their level. It pains me to see a kid was sent from Turkana. It comes a week, 2 weeks, a month, 3 months, 1 year later, when the disease has gone too far. They should be able, it's not very expensive, and they should seriously think about employing the right people in their hospital, so that Mandera level 5 may be far for somebody in Mandera, but it is too far or unreachable to come to Nairobi. At least they will be near home, where they can have follow-ups, they can have other support system. I can say in Kikuyu there is a low vision therapy clinic, where this kid, even if they are not going to see the doctor, they see the nurses and the teachers that know the schools that go around. The low vision therapy group goes around the schools, or they go around where they know that the child is. So they're able now to follow up the child with the teacher. So such groups, and like you said, health is a devolved unit, and the governors have seriously defended it, and I support them. But I think they need a lot to do a lot, and especially in this area of primary health care, where congenital glaucomas and other diseases that are found to be not very, or not requiring a lot of attention from the national government, they should look at. And I suppose that where they begin is actually employing specialists, because they don't. Specialists, you go to specialists in ophthalmology, and probably there's none in the whole, maybe I know one in Garissa, the whole northeastern. So Garissa, Wajir, Mandera, all under one person in Garissa. So they should aim to employ more specialists. You cannot attract a specialist with a very small Mianga salaries. Probably they need to have a bigger budget. And of course, once there's a specialist, the specialist is able now to look at what other support systems they need to enhance their work.
Okay. Yeah. Now for you, Dorcas, it's been 5 years. The child is doing well. As you said, your son is a special case considering or compared to those that you've seen in the clinics you go to. What would be your challenge to parents and also teachers and just the general society in dealing and supporting children living with glaucoma?
Okay, my challenge to parents with young children generally is that once you give birth to a child, you just be careful to look out for any odd thing you see in your child, either it's the eye, anywhere. Just keep keep an eye, watch out, and then if you notice anything odd, then you should immediately go to a healthcare and uelewe shida ya mtoto iko wapi. Then to the teachers, okay, urge them to be to be more concerned with the children. If they notice that any child is having any complication, then I think they should inform the parents. Okay, and generally, I'm calling on the government of Kenya, just like wametuwekea mambo ya family planning once a month, kwetu wanatuwekeanga once a month. Every time kuna free family planning, whatever. Then I'm asking the government of Kenya, they should also watuwekee specialists na watuwekee mambo ya macho, especially mambo ya macho sana, once a month, ndio watoto kama hao wenye glaucoma, wenye wanapoteza macho every now and then, they should ndio wajulikane mapema na watibiwe. Yes.
Okay, Daktari, in closing, the expense of the same very high. You mentioned earlier that the insurance covers are really letting down the whole support system in as far as treating and managing glaucoma is concerned. Your final word?
I would urge what we call private insurers in this case also to recognize that this child who is born with a defect, because almost all of them have an exclusion clause of congenital diseases. Once I mention congenital, then the mother is told we cannot support. This child has a lifespan. For Kenya, probably life expectancy is about 70 now. And you can imagine this kid being born blind or getting blind when born and then living this many years. And we are very quick, of course, they look at the cost, but we are very quick to insure an adult who is 70 years, who is about only have 10 years to live. They are very quick to tackle that. I urge that you think about children and congenital diseases as having to also support the health system in the country and the health of the citizenry, because that exclusion clause actually is very limiting. I'm happy about NHIF because it doesn't, they have no clauses, and the children that we are hearing, although they're also only covering surgeries, they're not covering, like what doctor says,
follow-up treatment,
clinic visits, kununua dawa. That's upon the parent. Probably they would enhance that in NHIF, and probably that would encourage or create competitiveness to encourage the private ones also to start looking at especially childhood diseases. Yeah.
Well, thank you, Dr. Dan Mundi, ophthalmologist, childhood glaucoma specialist, and Dorcas Wanjiru, a caregiver to a 5-year-old child born with glaucoma. We have been speaking about glaucoma in children, and it constitutes 6% of total blindness in children. Definitely a conversation worth having. It is within the Glaucoma Awareness Month, and many do not know how it looks like, what to do, and where to go. And that has been the conversation this morning. Even as you go forward, they have mentioned it is imperative that you as a parent caregiver be aware of what's going on with your child so that you can arrest it early enough, and for those that are stakeholders in the industry to invest in making sure that they give the support system needed for children or patients living with glaucoma. Thank you for your company on NTV Today. My name is Gladys Gashanja.